Hello, and welcome to this life event titled Getting into Focus with Agitation and Alzheimer's Disease, What We Know and Where We're Going. I'm Anton Porsteinsson. I'm the William B. and Sheila Konar Professor of Psychiatry, Neurology, Neuroscience, and Medicine, and the Director of the Alzheimer's Disease Care Research and Education Program at the University of Rochester School of Medicine and Dentistry in Rochester, New York. And joining me today is Paul Rosenberg, who is Professor of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine in Baltimore, Maryland. Welcome, everyone. It's a pleasure to have you, and please feel free to reach out via the possible connections that you have to us for questions or comments. So today we're going to talk briefly about agitation and Alzheimer's disease, including what it is, how we screen for it, how we manage it, and this is setting the stage for CME activities in year 2 of Medscape's clinical advances in diagnosing and managing agitation and Alzheimer's disease. Last year we did actually year 1, and it was really excellent. So let's start with what agitation is. Basically, when we think about agitation, we tend to use the so-called International Psychogeriatric Association consensus definition criteria. Using those criteria, basically, we need to have someone, the patient, that meets criteria for a dementia or a pre-dementia syndrome, such as Alzheimer's disease dementia or MCI due to AD. And they need to have persistent and frequent symptoms associated with emotional distress that have been around for at least 2 weeks, or a very sudden change in the situation that includes one of these 3 behaviors: excessive motor activity, verbal or physical aggression. The behaviors need to be associated with excess distress or disability that goes beyond the cognitive impairment, including impairments in interpersonal relationships. So this is with family, care partners, and even paid caregivers. It also could impact other aspects of social functioning or their daily activities. And the exclusion has to be that it cannot be attributed solely to other psychiatric disorders. And that could include actually substance use disorders. Now, it's rare for things to be completely clean. They're often comorbid conditions. But in this situation, we would expect those comorbid conditions not to be driving the ship here. So why is agitation important? Not only because it is so distressing, but it is incredibly common. You know, if you don't have agitation at one time point, to some degree, we say just wait. It is up to 76% of patients with Alzheimer's dementia and up to 60% of patients with mild cognitive impairment that at some point will develop agitation, as we listed by the IPA criteria. So maybe not all at one time, but at some point during their journey through this disease. The impact on the patient is quite significant. We talked about distress, but there's also a great impairment in the quality of life. There's much higher risk of having to move to a higher level of care. That could be the hospital, it could be an assisted living facility, it could be a memory care unit or skilled nursing facility. There is often excess morbidity and frequent hospitalizations, and there is accelerated disease progression. That is, patients that have Alzheimer's disease or MCI due to AD that have neuropsychiatric symptoms such as agitation and aggression, they tend to decline faster than those that don't. In addition to that, this is one of the most distressing aspects of providing care, so being the care partner for these individuals. For the care partners, there's much higher stress and depression, lower employment income, more health burden. Furthermore, there is a pretty significant impact on providers and healthcare system. That is higher number of consultations, increased likelihood of admissions to psychiatry, and higher direct as well as indirect healthcare costs. So how about approaches to diagnosis and management? And before we talk about the treatment for agitation, let's review how we approach diagnosis and management. And I'm going to punt it over to you, Paul.
Thanks, Anton. Yeah, so one of the favorite approaches to diagnosis and management is called DICE. And the DICE approach, it's a nice acronym, easy to remember. And it really covers a lot of the things we do in clinic and at home. First, you describe the problematic behavior. This is really important when I'm working with patients and families. Families will come in and say, so-and-so, my husband is agitated. And I go, that's interesting. Tell me more. You need to tell more. You need to define the agitated behaviors, because you might not make them go away. You might just make them less frequent. So you want to know which ones you're looking for. Investigate possible causes. Patient factors, for example, it could come from the dementia itself. It could come from misunderstanding, from disorientation, from sleep problems, from problems with language, misunderstanding social interactions. But could also come from medical illnesses like delirium. I think I'm going to be talking about that on another slide. It can be care partner factors. I think one of the hardest things for families to deal with is the fact that in dementia, the roles often have changed. A couple may have had sort of equal roles in taking care of each other, and now the non-demented partner, more often than not, is doing more care for the other partner. So things are not as balanced, and they don't feel right, and the care partner may be uncomfortable with this situation. Environmental factors. Dr. Porsteinsson mentioned level of care. One of the most important things I do for patients and families is try to advise them when they need to change the care pattern or the level of care. You may be home with your spouse, you may be home with your children, but I'm often advising people to bring in caregivers. Unfortunately, you usually have to pay out of pocket for paid caregivers, but that can be very helpful in care. But one of the biggest sources of agitation is having an insufficient level of care. Many of my patients that are agitated at home are going to do better in assisted living, just for example. Create a plan for management. Notice we didn't say cure, but create a plan for management. This might involve treating medical problems. It might involve adjusting medications, perhaps adding new medications, but my favorite part is getting rid of medications, but also educating the care partner and looking carefully at the level of care. And then evaluate. Well, DICE, describe, investigate, create a plan, and evaluate. I think monitoring the plan for success is the most important thing. And I think this is something doctors actually often forget. They write a prescription and they may not have a plan for exactly how they're going to evaluate the results. There's a number of other interesting acronyms. They all follow the same general pattern that with slightly different emphasis. So I just described DICE. Another one is called the DSA decision tree, I guess from the Neurology Association of America. Ask about symptoms, measure frequency and severity with the behavioral scale, and rule out other potential causes, and treat. It's a slightly different order than DICE, but it's the same general idea. And then there's the IPA algorithm, a different IPA. Investigate the behavior, similar to DICE, investigate the cause, plan an intervention plan, and what's important is that it should be tailored to the patient. These are very person-specific treatments. And using shared decision-making. You want the patient to be as part of the decision-making as much as possible. This will depend a lot on the severity of their cognitive impairment and the severity of the behavioral problems. And then the last part of the IPA is act, implement the plan, and assess effectiveness. But what all of these have in common is a real emphasis on investigating the cause. Once again, thinking about patient-specific factors like dementia, caregiver factors, possibly involving the need for education, and environmental factors, which may involve where you live. Common among all these frameworks: understanding the behaviors and what might be causing them before making a plan, individualizing the management plan to the patient, and assessing the effectiveness and adjusting as needed. So it's common sense, but these approaches sort of split up common sense into a number of steps so you can be sure you've been thorough. And I think that's very important here. What are some validated instruments to help assess agitation? We have, if anything, too many and not absolutely universal agreement on this. There's a new one, the Agitation and Alzheimer's Screener for Caregivers, that Dr. Porsteinsson called to our attention. Very nice kind of short questionnaire that you can use in the waiting room. It's new, hasn't been highly validated, but it looks really good. And I think I think it's going to enter primary care practice. The Cohen-Mansfield Agitation Inventory, which either has 14 or 29 items, whether you use the short or long version, developed by the psychologist Jessica Cohen-Mansfield, who was working at a nursing home in the Washington area. And if you look at the items, it's very oriented toward advanced dementia and nursing home patients, including things like strange noises and eating things that aren't food, and so on and so forth. It's probably the best validated scale, although I tend to think of it more useful in advanced dementia. The Neuropsychiatric Inventory Questionnaire, probably the most widely used. In this form, it's usually administered to the caregiver, who rates their 12 domains of symptoms, and they rate the patient and different versions. Some of them rate the frequency and severity, some rate merely the severity. This is an easy one to use in the waiting room as well, although you get a lot more noise if you just give it to people and ask them to fill it out than if you administer it yourself. A lot of barriers to using these instruments. Limited time. Clinicians are not that familiar with them. And once again, I think I'd say in terms of the bias of the care partners, I think everybody's got their own threshold of reporting. And some people are much more likely to report symptoms than others. So you can have caregivers who amplify symptoms, caregivers who minimize symptoms. And that's, I think, the biggest problem with using questionnaires you give to the caregiver. This brings us to management and treatment. Once we determine that the symptoms meet the criteria for agitation of Alzheimer's disease, what are our treatment goals? So the GSA decision tree and the IPA algorithm focus on prevention and amelioration. So you've got identifying and addressing causes and triggers. It's a team effort with the caregiver and the patient. I would say the amount you can involve the patient in the decisions depends so much on their level of cognitive impairment. Frequently, when you're dealing with agitation, you're dealing with severe cognitive impairment, and it isn't that easy to turn to a patient with very advanced disease and say, hey, can you help us to help you stop slugging your spouse? It's sort of a nonsensical statement, but it's sometimes worth asking. And you develop a plan with specific actions. What's important is to have specific goals. Anton, please chime in if you like.
Yeah, and Paul, I think you put it very well, and that is that people don't like being excluded from the conversation. And I find people that are agitated are often quite aware of the fact that they are difficult, that they are a burden, and that they're distressed. They may not always have insight into it, but I think it is important to actually validate how they feel. Ask them how they're feeling, and validating. This is tough. This is not only tough for your wife or your daughter, but this must be hard for you. And hearing that out, because I think that regardless of the setting that you're in. It's important to build some sort of a therapeutic rapport with people. And they are the patient. They are the ones that we are taking care of, that we should be focused on. And I think that the other thing that I find really important is to be clear with the patient and the care partner, or if this is within a system, could be in an assisted living facility or long-term care, that you're clear about, here are the recommendations, who is responsible for what. And that could be as simple as asking the patient to make sure that their loved one knows how they are feeling, and if they think that things are getting better, to make sure that the care partner has an open communication back to you, is able to somehow report, this is better, this is working, I don't know if this is doing so well, so that you can do the evaluation and the reconsideration part of DICE. So, what are the specific actions? Who is responsible? How does the team communicate? It's rare, like you pointed out before, Paul, that we completely cure this. But if you reduce the frequency and the intensity of the behaviors, maybe by about 30%, it can take it from a situation that is completely unmanageable, where everyone is burning out and everyone is, hopelessly frustrated, to a point where it is manageable and you've kind of depressurized the system. So I think that it's also important to kind of talk about what is likely that we can bring about here. And obviously then talk about what are the paths that we are going to take. And, non-pharmacological treatment options are always supposed to be primary when you intervene. And Paul, you are somewhat of the resident expert in our circles on that. And I'd love to toss that over to you and kind of get your thoughts and ideas on how you apply those.
Thanks for those perspectives, Anton. And let me just add one thing before I move on to what's on the slide here. There's a basic principle in Alzheimer's disease: play to the patient's strengths. And keep in mind that for the most part, Alzheimer's disease affects cognition far more than the person's underlying personality. So most of us, one of our strengths is our social relationships, and bringing the patient into the decision making is playing to those relationships, because the patient may not remember that they hit their wife or wandered out at 3 a.m. or ate inappropriate something that isn't a food, but they do remember that they love their family. Mm-hmm. People, for the most part, don't forget that, and if you break them part of the decision making, you're really playing to that strength. So let me talk now about general approach to behavioral and non-pharmacologic interventions. It's an area where there's a lot of good ideas and no cookbook. And I think what you do in this area is you apply the ideas and use your own creativity and knowledge of the situation. So first of all, focusing on the care partner, who for the most part is the first focus in the clinic. You may want to they may need education about the disease. I find care partners need to particularly understand, they know about memory problems, but they don't always realize that they're part of the disease. They think that their loved one is forgetting on purpose, that it's volitional. And it's important to be able to detach and say, no, this is a disease talking here. They also may need education about agnosia, not recognizing things, and aphasia, troubles with language. We want to enhance communication between the care partner and the patient, and as much as possible, get them talking to each other instead of having to act out in agitated ways. You want to create meaningful activities for the patient. This is where you've got to individualize things. There's no prescription I can write to say what people like to do. But in general, I think the first principle of behavioral treatments is distraction. Person's agitated, they're usually distressed. Find something they enjoy. I particularly want to emphasize, actually on the next slide, we'll get to that, music. Another thing is to simplify tasks, break them down into single one thing at a time tasks. Showering is a great example, because to shower, you need to get to the bathroom, find your towel, turn on the water, take off your clothes. I'm sorry to bore you with this, but there's a lot of different steps. And a person with advanced dementia, you can't simply say, go in there, get the towel and turn on the hot water and take the shower. Too many things.
And Paul, we sometimes call that executive dysfunction agitation, because they just get overwhelmed and.
Yes, and it's important to have structured routines. A lot of caregivers are so stressed that they lose track of the idea of let's have breakfast, lunch, dinner, nap time, let's go out of the house. But it's one of the things we do in our psychosocial support interventions. First thing we do is just say, let's make a weekly schedule. Let's see what you're doing every day. And it is literally as simple as breakfast, bathe, indoor activities, lunch, take walk. It's simple stuff. But having some structure to the day can be very calming for patients. Patient-based. There's actually quite a bit of research on activities that help agitation. I'm a musician by hobby, as Anton knows, and I'm very
the good one.
and I'm very interested in music therapy. There's actually quite a bit of evidence that music therapy can help patients calm down and increases their satisfaction with life. And it's got a neurobiologic basis. People often retain the ability to process music when they are having troubles with language. In other words, they can have substantial aphasia, but they can sing, they can dance, they can enjoy listening. My favorite is if people play instruments, but you don't have to do that to enjoy it. Therapeutic touch and massage has some track record. It's a little hard to standardize the intervention, but it is important to hug your loved one when you get a chance. And there's a little bit of evidence on aromatherapy. I wish the evidence were stronger, because I love entering a room where they've been doing aromatherapy, but it's certainly something to think about. People sometimes create these rooms, I don't know how to pronounce it, snoozalin or snoozalin rooms, where things are calm, they have lava lamps going, they have aromatherapy, they have calm music. It's really a nice principle for patients as well. In terms of environmental changes, simplifying and enhancing the environment for safety. Well, one of the things that we do at Hopkins is we have a home evaluation. And I guarantee you every single home evaluation starts with get rid of the throw rugs to minimize falls. But there's a lot of other things you can do to make the environment simpler and less stimulating, so that people see. I think clutter can be very disruptive for Alzheimer's patients. Each time you have a serious event of agitation, take a look for triggers and see what brought it on. Is the patient tired? Are they hungry? Was there a transition between caregivers? Is it too hot, too cold? Actually, the question of stimulation is a really interesting one, because most of us, if you left us alone in a room without a specific activity, we might get bored. But for patients with dementia, having too much to do, too much in the room, too much clutter can be too stimulating and cause agitation. This is something you really have to individualize for the patient. And with that, Anton, I'd like to turn it back to you to talk about pharmacologic treatments.
Thanks, Paul. And, I just want to make a point that spending some time on non-pharmacological intervention, psychoeducation, education about the illness, that the illness is driving this, that it's not volitional, that someone hasn't turned kind of evil in their old age. I see that more often than you'd think. And so helping people a little bit with this can make a big difference. But non-pharmacological interventions work best when the agitation is without aggression, and when it's relatively mild or maybe early moderate severity. So more often than not, when you have moderate or severe behavior where someone is at risk, or the non-pharmacological interventions don't work, you have to turn to pharmacological treatment. And that is also a little bit of an art and a challenge as well. What you find out there is that there isn't necessarily a lot of options that have very substantive data behind it. And so basically, you find that prescribers, be that physicians, nurse practitioners, PAs, or others, have their favorites. But it's important to understand what is the data supporting them and what is actually the side effect profile, and make sure that it fits the participant. So when pharmacological treatment becomes necessary, what are our options? Basically, we only have one medication that is approved by the FDA for the indication of agitation and aggression in Alzheimer's disease, and that's brexpiprazole. And that is based on 3 different studies that kind of formed the pivotal foundation for brexpiprazole. But brexpiprazole, as you may know, is maybe a 3rd generation atypical antipsychotic. And it does have a boxed warning, like most of the, or all of the, both conventional and atypical antipsychotics have. There are multiple medications that are used off-label, so other antipsychotic medications. We still see conventional antipsychotics used, although I don't encourage this, and atypical antipsychotics such as risperidone, olanzapine, quetiapine, aripiprazole. There is some use of cholinesterase inhibitors, but they don't work very well if you are trying to kind of bring acute behaviors under control. And in some situations, they may actually make things worse. The same goes for memantine. Antidepressants may have a role. We have data for citalopram being helpful, but associated with some side effect burden, QTC prolongation, falls, worsening cognition. And we just presented the top-line data from our escitalopram study, where regrettably escitalopram did not show that it was in any way superior to citalopram, and also actually had a QTC prolongation and increased risk of falls. So there are a number of investigational pharmacological interventions. Probably furthest along is dextromethorphan bupropion, also referred to as AXS-05, where we have 2 studies, both a placebo-controlled one and then a relapse prevention study that showed it was superior to placebo. And we should have 2 more studies coming out in this last quarter of the year. And if they are positive, I expect that this drug will be submitted to the FDA for approval. We are seeing cannabinoids and THC under study, and Paul and his group just showed that dronabinol was beneficial for this indication, and so we can think about what maybe a use of THC and cannabinoids that are received through dispensaries or medical dispensaries might be. Dexmedetomidine in a sublingual form or buccal form as a thin film is being studied and used for acute agitation. So there are some ways of looking at this. There are pharmacological treatment algorithms from the International Psychogeriatric Association, as well as from the APA, the American Psychiatric Association, that may guide you along in terms of picking the right options. And but a lot of that is actually kind of again very individualized. You pick the medications that may cause the least problem for the patient. And it's important to involve the family in this decision making as well. And I want to be mindful and respectful of time here. But any golden nuggets about that, Paul, before we keep going here and start wrapping up?
Yes, this is an area where assessing risk, and you constantly assess risk and benefit. And with medications, you got one FDA-approved medication just last year, which means everything else isn't FDA approved. And I think you pick and choose your medicine based on the severity of the agitation and the risks associated with it. So the whole class of antipsychotics probably has more risk than most antidepressants, although we're not sure. We tend to start with antidepressants, but they're often not that effective in severe agitation. So once again, it's got to be a partnership between the clinician, the family, and the patient.
And I've found that, for example, brexpiprazole is particularly effective when there's a mix of either verbal or physical aggression into the agitated behaviors. So wrapping up, as we've discussed, agitation is a distinct entity that causes considerable distress to patients with Alzheimer's disease and their care partners. We need to increase the awareness of agitation in AD so that we can provide our patients with optimal care. And a lot of that, requires education for prescribers. And Medscape clinical advances in the diagnosis and management of agitation in Alzheimer's disease is really a very comprehensive learning center for clinicians managing patients with Alzheimer's disease. The year one features was basically, an assessment, began with an assessment for clinicians to gauge their understanding of agitation in Alzheimer's disease. There was a foundational spotlight on symptoms, diagnosis, and management. We had an expert-to-expert discussion on diagnosis and peer-to-peer series on best practices in management. Year one outcomes, more than 32,000 clinicians engaged. More than 139,000 patients were impacted. 93% of the clinicians said this indication would have an impact on their practice. 86% committed to changes in screening, in prevention and treatment of agitation in Alzheimer's disease. Knowledge about AAD increased by up to 35% among physicians, and the ability to apply this knowledge to practice increased by up to 15%. And up to 40% of clinicians reported increased confidence in their ability to manage AAD. So please stay tuned for year two, because that will be a new suite of activities to enhance clinicians' understanding of agitation in Alzheimer's disease and how to manage it. And I want to thank you for your patience. Thank you for staying with us here. And very much, Paul, as always, thank you for this great discussion. And to all of you in the audience, thank you all for joining us today.
And we thank Medscape for giving us this opportunity to talk about one of our favorite topics.
And with that, have a great rest of your afternoon.